and welcome to Lessons from the Lab. I'm Devin Rubin from Mayo Clinic in Jacksonville, Florida. I'm here with you for another episode of Lessons from the Lab. I am fortunate to begin this day with a great guest, a very experienced electromyographer. He's done this for many years, and I'm going to present a case that's a pretty straightforward case, something that you've all probably encountered in your practice, but it has some twists in it that make us scratch our head. We're not really sure what we're getting into. So sit back and enjoy this episode. Welcome to another episode of Lessons from the Lab. It's a pleasure to have a wonderful guest and a wonderful friend join me, Dr. Carey Levin. Dr. Levin is a professor of neurology at Cleveland Clinic. He's an expert EMGer, neuromuscular physician, and I am excited to have you here, Carey. Nice to see you.
Well, thank you very much for this invitation. I enjoy talking about my favorite subject, which is EMG.
Well, great. Well, you know what today is, right?
Today is Valentine's Day.
Well, that's not what I was going to say. I was going to say today's a special day that I get to talk to you, but it is Valentine's Day. Yeah, that's right. And I've known you for a long time. We each have our own Valentines, sweethearts at home, but I think of you a little bit as a work Valentine. We've done a lot, my Valentine through work. We've done a lot together. We've written lots of exam questions, given talks together. So it's nice to spend a little bit of Valentine's Day with you.
And I feel the same way. Devin, you and I have had not only a friendship, but a working relationship that I've enjoyed very much.
I was thinking back this morning as I was getting ready for this, and I don't know if you'll remember this. This will date us a little bit, but a number of years ago, we were, I think, at a meeting. It was in California, and we went on a little hike. And I remember the hike. I don't remember exactly where it was, but you were teaching me, or I was asking you how Wi-Fi works with our cell phones. And this dates us because it was like right when cell phones were kind of coming out, and I didn't understand how Wi-Fi works. So I won't ask you to explain it today, but I've learned a lot more than just EMG from you.
I would have to say that I think this is an apocryphal story because I would not consider myself an expert on internet and Wi-Fi.
I think you just said you just push this button on your phone and you can get service. And I said, okay, I believe everything Carey says. So, our conversation today, I think, will be something I know you will be able to explain to me and to our listeners. I know you've been doing this. We both have for a long time, but you've been, how many years have you been performing EMG?
Over 40.
Okay. Do you ever get tired of it?
I seldom do a full day of EMG, but that can be tiring at the end of the day, doing a full day of EMG. It's nice to have a diversity in the work you do. And so having a combination of procedural EMG and seeing clinical patients and being able to correlate those two, I think makes a profession in neuromuscular medicine so much more rewarding than one without the other.
Yeah, I agree completely. I know we agree on almost everything. I agree. And the weeks I'm in clinic, I think, gosh, I can't wait to be in the EMG lab. And the weeks I'm in the EMG lab full time the whole week, I love it. It's just fantastic, but it's tiring when, I'm sure at Cleveland Clinic, at Mayo, we do lots of EMGs and lots of patients. And sometimes it's just hard to sit back and sort of take a deep breath and think about the patients as much as we want. And that can be tiring in a good way, in a good way.
Yes, and there are challenges in both of those areas. There are challenging patients, not only from the diagnostic and treatment point of view, but we're dealing with human beings, and there are stresses in the EMG lab, just getting a study done and getting a patient through a study. And there are challenges getting a clinical patient through their illness.
Yeah, yeah, absolutely. Well, I'm going to give you a patient that I think will be challenging in some ways. One of the goals of this lessons from the lab are to help educate anyone who's watching this or listening on podcast as to how we might approach a patient that we might encounter in the lab. As you know, not every patient's textbook, and so sometimes we have to scratch our head and think a little bit. So I'd like to present you with a patient that we had in the lab a few weeks ago and see what you think about this. So you
Sounds
up
great.
for it?
Yes.
This is your Valentine's Day present to get a talk through a patient. So I'm gonna just show a few slides here and share my screen. So hopefully you can see that.
Yeah.
So I'm gonna just read this for those who are not watching but are on podcast. So the patient is a 40-year-old man who presented to the EMG laboratory with left leg pain and weakness. And his story was that he had a long-standing history of low back pain. It had been going on for over a decade, and he would have these flares that he would call a few times a year. He never had surgery. It was always treated conservatively. And then about 5 or 6 weeks prior to his presentation, this time he developed pain that was unprecipitated by any type of injury or trauma. And the pain radiated in his left buttock down into the hamstring area. He did report some numbness, which he described as a loss of feeling in the bottom of the left foot and the top and bottom of the toes on the left. And he noted that he was a pretty active guy, and he noted that during this time he had difficulty standing up on the toes on the left foot. So he saw his primary care physician. He was treated with a Medrol dose pack, and about a week prior to him coming for his EMG, he felt that there may have been some improvement in the pain, but he still had all the other symptoms. And of course, what we always do when we see a patient, and he didn't have any other real medical problems that were significant. So real no systemic medical conditions. He was healthy. And then I'm just going to give you, the exam, of course, is very important. And his exam was pretty straightforward. It was all normal except for an absent left Achilles reflex. And he had some weakness in his left gastrocnemius. The other muscle strength in his leg was normal. So that was the story. That's how he presented. He was sent for an EMG for this. So have you ever seen a patient like this?
Many times.
I would say, let me ask you, in 40 years of doing this, how many patients would you say you've seen, if you had to guess, that have been sent for symptoms similar to this?
Oh, hundreds.
Yeah. Okay. Sometimes I think, this is just an aside, I think of I don't know, sometimes when I'm bored and I'm needling a patient and I think, how many motor unit potentials have I seen in my life? Have I recorded in my life? You think you've recorded, you think you would have hit the 1,000,000-mile club, like on the, like the airline's 1,000,000-mile club, the 1,000,000 motor unit potential club?
Yes, I think so. Sometimes I think about how many EMGs I've done in a year. And although I've cut back a little bit because I have other administrative duties, I may do 1,000 or more EMGs easily on a yearly basis. And so over the course of years, that adds up.
Yeah, and if you think about in a patient, I've thought about this. Again, this is how my mind thinks. If in a patient, in any muscle, you collect 20 motor units and you do about 5 muscles in a patient, on a routine patient, that's 100 motor unit potentials. So you're doing 100,000 motor unit potentials in a year. So you're at the 4 million club.
The interesting thing to reflect on is that in spite of how many you've done and how many I've done, I enjoy doing normal patients of all ages, because by normal, I mean they have symptoms, but you don't find much. It just further refines my range of normal, um, and therefore allows me to have a more refined sense of what is abnormal and where I shouldn't be overstepping my diagnostic skills and overdiagnosing, because there's a spectrum of normal. There are some patients who have bigger motor units, and it doesn't mean that they have abnormalities.
Yeah, I agree. I mean, how many patients, if you think about it, do you start needling the leg? Like maybe a patient like this, you're doing a needle exam in the anterior tibialis, and you sit there, that's your first muscle, and you're not sure. And you know, on our grading scale, I don't know if in your grading scale of size you have a plus minus on your scale. So meaning equivocal. We tell our residents they can't use that. That's only for staff that can use equivocal. They have to commit, but I use it all the time. And just like what you're saying, that I don't know for this patient, it seems maybe a little bit large, but maybe this patient's motor units are large. So I'm not sure until I see the other ones.
Yes, and in our lab, we have the descriptor 0-1 plus. And I remind, so irrespective of what column we're talking about, the fibrillation column, the fasciculation column, the large motor unit column, and I do tell our trainees that it is the last refuge of the EMG scoundrel, but it's trying to be honest.
Yeah. Right. I tell them you can't use it. They're showing me a waveform. You can't use it. You have to commit. You can't say plus minus. I say, what do you think? So they'll either say, well, I think it's normal, or I think it's +1. And they'll say, what do you think? And I say, I think it's plus minus. So we're
Yes,
allowed to. If you've done this for over a certain number of years, you're allowed to equivocate, right?
and I think in this kind of a case, when you go to the actual study, yes, you're looking at the gastrocnemius, but you're also interested in what do the other muscles look like. And because you're building a case, you can't build a case on one muscle.
Yeah. Yeah. So backing up then, so for this case, if you maybe share what you would be thinking before you start doing any testing in the lab, and this is the information you have, what's going through your mind?
So I first of all want to confirm with the patient the symptoms, the side of the problem. Is there anything that might also be going on the other side at the same time or in the past? And I want to think about what we do have the luxury in my laboratory to have technical staff who do the nerve conduction study. So I scrutinize those and make sure I agree with the waveform analysis that and the nerve conduction study metrics that have been generated by the technologist um, uh, before I decide, well, what's my attack plan for the needle exam?
And just in terms of, I don't think this is a surprise, but in terms of what you're thinking before you do anything with this case, in terms of possible localizations, what would you be thinking?
Um, well, I'm going in with the bias that this is an S1 radiculopathy. Um, and I'm already thinking about how am I going to prove that? And will there be roadblocks in the way? I can already imagine, having done so many of these, that I may be thwarted uh, with a limited examination. I'm going to need to look at proximal muscles as well as distal muscles. I'm going to have to frame the abnormality to make sure that I'm convinced that it's a single root lesion and what the localization could be.
Okay. And in your lab in Cleveland, are the conduction studies performed first, or is the needle exam performed first?
We almost always do the nerve conduction studies first. I think that helps understand the context in which the needle examination has to be performed. For instance, we might find out in this patient, he's only 40, but if he has sensory conduction study abnormalities, that will change my thought process about how I understand the needle examination and what I'm going to have to do to rule out or rule in other things that are going on top of what I end up finding.
Mhm. Okay. So, and it's similar with us. Most patients, we do the nerve conductions first. We're like you, we have great technicians who perform these. Um, I'm curious, in your lab, from the nerve conduction standpoint, do the techs just go in and they have the protocol, and they know what to do, or do they ask you first which conductions? And if they did ask you, what conductions would you tell them to do in this case?
So our studies in terms of nerve conduction studies are quite protocolized so that we get a sense from the referring diagnosis and the symptoms and signs that have been provided to us that we're going to be doing a leg, uh, or we're going to be thinking about a bilateral problem. And the technologists, therefore, have a roadmap to begin with. Now, they are also trained and experienced well enough that they branch out into other things depending upon what they find. So if in a case like this, the sural is absent, they're going to check the other side. They may not check the other side if the sural is fine on this side, because we're going to need to know, is there laterality of that problem, or is this a symmetrical issue, and how does that play into the rest of the exam?
Okay. So your routine studies in this case would be, you would do what, a couple motors, fibular and tibial motor?
Yes, exactly. We do both of those. We do a sural, and we do a superficial perineal sensory response, and we do an H reflex.
Okay.
And if the H reflex is abnormal, we always compare with the other side.
I'm curious, I'm going to show you some waveforms here, but so you routinely do H reflexes, and what do you use? And we don't do them very often. So this is why I'm asking, do you use an absolute latency is there an absolute latency prolongation that you use, or how do you interpret it if you're looking at one side that it's abnormal?
We don't pay much attention to the latency. Uh, we pay more attention to the amplitude of the soleus M response and to the actual H reflex amplitude. And our cutoff is 1 millivolt for the H reflex amplitude. And if it's less than 1, that automatically signals need to do it on the other side. And so that's kind of our go-to. If it's absent, the H reflex, we always check the other side. You know, there are lots of patients who may end up having absence on both sides, and that could be technical because of body habitus. It could also be because you're over 60, but that's kind of our cutoff for expectation of the presence of an H reflex.
Would you be comfortable calling an S1 radiculopathy only on the basis of an abnormal H reflex, with everything else, including the needle exam, being normal?
No.
Okay. I had an interesting H reflex, just an aside. A week ago, we had a patient. Again, we don't do this very often. We do it about a handful of times a year, and mostly to show the techs and the residents how to do them. But we had a patient, not this patient, that came in with left buttock pain going on for a couple weeks, a little bit on the right, and had absent Achilles reflexes bilaterally. And everything was normal. Needle and routine nerve conduction studies were normal. And it was the last case of the day. And I said, well, let's just do H reflexes for the heck of it. And you know, I often thought, well, if they have absent Achilles reflexes, we're not going to get a good H reflex anyway. So we did it on the affected side and had a beautiful H reflex, high amplitude, beautiful. And we went to the other side and I couldn't get one on the unaffected side. It didn't make sense. It was the wrong side. Actually, we got something, but it was a very low amplitude. So I said, this is why we don't do them. I don't understand. I mean, he
Yeah,
may have had an old process affecting that root in the past, but which is probably the case. But
yes. And
his,
yeah, I would have been interested in the soleus M responses as well. Was there an asymmetry there as well? And I mean, because that might have informed you about why there might have been a low
yeah,
H.
yeah.
Uh,
And I didn't needle the unaffected side, the gastroc. So there may have been old changes too.
but I'm well aware of the kind of sometimes mismatch between presence of H reflexes and absence of Achilles reflexes, and it does give you pause. And sometimes it's the other way around also.
Yeah. And I think with the technology too, I think, when I was a fellow, I learned, yes, if you don't have an Achilles, you're not going to get an H. But I think now with the technology and the sensitivity of the machines and the ability to change the sensitivity, that when I do them, even if I don't think I'm going to get something, sometimes there is a really low amplitude one that's consistent. So you still can pick it up sometimes when they don't have a good reflex.
I think the other point about H reflexes is there's an art to doing them. And we sometimes run into trouble even with our experienced techs that they overcall an
Mhm.
H reflex, which really isn't there. So I'm kind of a stickler as far as the expectation that the amplitude of a normal H reflex should increase for a while as you increase the voltage of the stimulation. Uh, and it should then decline. And but it should be relatively robust to begin with and then decline. But if you don't get that, then I think there is either a technical problem or you somehow have to explain it.
Yeah. Well, good. That's a good conversation discussion about H reflexes, which we did not do in this patient. So, but it's good. I mean, because we think about it, and like I said, I did do it in another patient, so I don't think, I don't think they shouldn't be done. I think there is value in them. Certainly, if patients have mainly sensory symptoms and you don't find changes on the routine studies too.
So let me ask you an unrelated question, which is if the question is polyneuropathy or GBS, uh, not that they're the same, but a polyneuropathy question or a GBS problem, would you do H reflexes in general in those patients?
Well, I'll be interested in your answer, but my answer is, as I said, we don't. I think for a routine polyneuropathy, and I know there's data that suggests they're very sensitive, but for me, because I'm looking at a distal length dependent process, I think the routine conduction studies are going to be more useful for me. But the times that I'll consider doing them in a GBS or even a CIDP type of problem is in a GBS that's sensory predominant or a CISP, the chronic inflammatory sensory polyradiculopathy, where the patients have severe profound sensory loss, absent reflexes, and the routine studies are all normal. And I'm looking for a proximal block of the sensory pathway. So those would be and those are rare, but those are the times that we'll do them. How
Yeah.
about you?
It is part of our routine workup for a polyneuropathy. I'm reminded of what Dr. Jun Kimura told me years ago, which is that and I think this has been backed up by some uh, electrophysiologic research on diabetic neuropathy, that loss of the H reflex may be one of the very first features of diabetic neuropathy, maybe even before sensory responses drop at the foot. Uh, like the sural or superficial perineal. So we do them
Mhm.
routinely.
Yeah, good. Well, that's interesting. Well, let me show you what we did do here. I'm going to show you a couple waveforms. So we did do, we start with the fibular motor, and you can see what's nice for those who are watching, and I'll just mention for those who are listening, if you're looking at this, green is normal. So these were all within normal values, the latency, amplitude, and conduction velocity.
Okay.
Would you agree? I don't know if you can see that well, but
Yes, the millivolt amplitude is 4.4, 4.8. So yes,
yeah. And no, and the things that we look for, not necessarily in the patient where we think is a radiculopathy, but looking for similarity and all the things, looking for dispersion and block, and we don't see any of that here. Do you perform F waves?
we do on the tibial response, but not on the EDB.
Why not on the EDB?
Unreliable.
Okay. Well, we did on the EDB. What do you think about that? There's a bit of an artifact here. If we ignore that, I'm not sure what that artifactual is, but this is the F waves. Would you agree these are reliable there?
Yes.
Okay. I agree that oftentimes we don't get them in the fibular nerve. So when you do F waves, let me just ask you this, do you interpret them based on absolute latencies, or do you do a calculated estimate?
We'll do an estimated, the staff may do an estimate if there's an abnormality apparent. Yes.
Okay. So we always calculate, our machines are set up to calculate an F estimate based on the routine conduction velocity between the knee and the ankle and the distal latency. So we assume the conduction time's the same in a normal nerve all the way up to the spinal cord and back. So we calculate, the estimated latency was 55.8 and it was 54.4. So that was good.
Good.
And then we did, oh, go ahead.
Latency and velocity, if you will, relatively unreliable in a focal lesion because this is a conduction across a very long distance, and the abnormality across the very short distance at the root level will be diluted out by the very long normal conduction along the F wave.
Yes.
So we're more interested, yes, we look at latency, but we're more interested in, is it there?
Yeah, that's a good point. And in fact, I'm not sure in this case why F waves were performed, because we've changed our protocol in patients. We did this a number of years ago in patients who are sent for radiculopathy, where that's the high index of suspicion. So neck pain, back pain. We stopped performing F waves routinely because we felt that for the reason you said, they're not very sensitive, they're not very reliable, and we were uncomfortable if the F wave was just slightly prolonged and that was the only abnormality, calling that a radiculopathy. So we do perform them in neuropathy because we're looking for proximal slowing, but if it's just a single limb radiculopathy, we often don't perform the F waves. But they were performed here. So, and then here's the tibial motor. So you think amplitude's 5.3 at the knee, 5.8 at the ankle, velocity is 47.
Latency 5.2. It's looking okay to me.
Yeah, looks pretty good. And then our tibial F waves were also nice and reliable and within the estimated latency.
They're interesting in terms of how long they are.
Yeah,
I don't remember seeing F waves that are so prolonged, but it looks
like almost like a dispersion.
Yes.
Yeah.
Interesting.
And yeah, it is always interesting because, as you know, tibial F waves always are a little bit dispersed, probably because you're picking them up from multiple different foot muscles. We don't pay attention. I know you mentioned Jun Kimura, who's done a lot with F waves and other parameters in terms of F wave dispersion, and we don't look at that. And maybe we should, that, measuring out the dispersion and comparing that to normative data.
That would be an interesting thing to think about.
Yeah. So here's the Searle. So patient's 40 years old. We perform, I don't know if you do this, we perform at 3 sites, A, B, and C, so 7 centimeters, 14 centimeters, and 21 centimeters. And our reference value for amplitude we use at 14 centimeters, and it was 3 microvolts here.
So this is an excellent example of what, well, you may prove me wrong, but that my technologist would come out and say, well, we've got a small Searle, and I would look at this and say, there is no Searle.
Okay, so you think this is just baseline?
Yes.
Okay, I think we agree on most things, but I'm not sure I agree with you on this. So I think it's messy. I agree with that.
I think my Searle looked better than this when I was 40.
Well, yeah, I don't think this is normal. I'm not sure this is normal. It's the amplitude's 3. It should be higher than that for a 40-year-old.
And that's interesting because a 3 microvolt response does come close to the baseline kind of oscillation that we can see.
Yeah. But
I
what do
think,
you think? I mean, do you think if you look at these 3, just look at the latency shift, and
yeah,
there is a wave, seems like there's a waveform here.
in any event, at his age, it's abnormal.
Yeah.
Wouldn't you agree?
Yes. Yeah. And what I would do just from a technical standpoint, what I would have done, they average 4 to 6 responses, and I would have averaged more. I would have probably averaged 10 or 12 just to clean that up and make sure that these are real responses. But I think those are real.
Okay.
Also, I know the case. So, but that doesn't change anything. So then they did the medial plantar here. So would you have done that or just done the superficial fibular?
Well, if we were looking for neuropathy, and we thought the Searle was there, we would do a plantar. But I'd say that that in a case where we're looking for a radiculopathy, we probably would not have gone to a plantar unless we thought this was a tibial neuropathy, in which case then we need to be looking at specific tibial related responses.
Okay.
I don't think that's there either.
Yeah, this one I was just about to ask, what do you think about this? What would you grade it, an A, B, C, or D, or F?
I'd give it an F.
Okay. So you don't think there's anything there at all?
Well, I mean, is that a shock artifact that not a shock artifact, but a motor response that it's, that comes after it? It's just unreliable.
Yeah, and I agree with you. This one, when the text, if our texts are fantastic, but we all know some patients, some nerves are tough, and there is a large shock artifact. And when they come out with this, I say I don't like this. We need to redo it or try it again. And I don't know. I don't know how much because you have great text too. So I don't know how much you're hands-on doing conductions, but would your text, or would you have any tips on how to clean this up or see if it's reliable?
I think it may be harder to do um, in the foot than it is and the fingers, where you can isolate the fingers and lift them up a little bit so that you're getting less volume conduction from close by
Yeah.
structures. I'm not sure how easy it is to isolate at the foot level.
Yeah. Yeah, sometimes what I'll suggest is trying to move that stimulator a bit more distal, so you're not directly stimulating the fascia or the muscles. So go distal, but that will drop the amplitude. But sometimes that will be enough that gets rid of some of that shock artifact, so you actually can see if there's a reliable response. That's a little tip that might be helpful. But I agree, these can be difficult. If we assume that this is response, it's 7 microvolts. So again, that's kind of borderline for someone his age in our lab, if that's real.
Mhm.
So they did go to the other side to compare, like you said earlier, and the Searle on the other side. Do you believe that one?
Yes.
Okay, good. And it's 10. The amplitude at B point's 10, and it was 3 on the affected side, if it was there. And they did a medial plantar, and
Mhm.
looks nice. It's 11 microvolts and clearly a nice response there. So that's all the conductions. They didn't perform superficial fibular sensories here, just those, and they didn't do H's as we discussed. So so with this case, just what we have now, what's going through your mind? We have the low Searle and medial plantar, but everything else is normal.
Right. So I'm a little concerned that S1/tibial sensory fibers are affected on the symptomatic side. It would have been interesting to know what the H reflex was on this side, because that plays into the question of a tibial, proximal tibial neuropathy, or perhaps a tibial neuropathy even at the popliteal fossa. But in any event, I also think about the possibility that sensory S1 fibers could be affected in an intraspinal canal lesion, such as a radiculopathy. And in my experience, that's much less likely than if we're talking about an L5 and a superficial perineal response, where the likelihood of a dorsal root ganglion, an L5 dorsal root ganglion in the foramen or internal to the foramen or intraspinal, much more likely anatomically than the S1 DRG, so that we do see cases of loss of the superficial perineal response with L5 radiculopathy due to intraspinal lesions, but in my experience, much less likely at the S1 level.
Okay. And we haven't brought up plexopathy. Could this be a sacral plexopathy?
Sure. I
Yeah.
mean, at this point, it's anything from the exit zone of the S1 nerve root down through the sacral plexus, the sciatic nerve, and below, tibial.
Okay. So if you were going to do your needle exam, which we would do, can you tell me the muscles that you're anticipating that you're going to examine? And I know it depends on what you find, but if you kind of are going into this, you're thinking, these are the muscles I'm likely going to examine.
We usually do our routine, and then I'm going to add. So I start with the tibialis anterior because it's most of leg muscles, it's fairly easily tolerated, and the patient gets used to what it feels like to have a needle in a muscle. Then I go to the abductor hallucis because that will be a little less comfortable for some people, and I don't want the foot to cool off before I do that muscle. So I would do TA, then abductor hallucis. I do the posterior tibialis muscle. Some people do the flexor digitorum longus muscle. I would do gastrocnemius and then an anterior thigh muscle. And then I would review, well, what do I have? I am if I find abnormalities in any of those muscles below the knee, and with the nerve conduction studies that we have, I'd be needing to do posterior thigh muscles and end up in gluteal muscles.
Okay. That's good. Yeah. And of course, it depends, like you said, on any of these. I think a good teaching point for everyone, especially if someone's new to this, is yes, we go in with an anticipated idea of these are the muscles I think I'm going to do, but that might shift depending on what I'm finding. So it's never a set textbook or cookbook approach, because sometimes we find things we don't expect to find in muscles. So I'm going to just show you the table of what was done just for the sake of time, and want to get into a few points. So our approach, and this is interesting when I do these, everyone's approaches is a little different. I started with the anterior tibialis, which was normal, and went to the medial gastrocnemius, which showed 2+ fibrillation potentials and some mildly long duration. Here's my plus minus long duration motor units. So for me, I wouldn't go down to the foot knowing that the gastroc's already abnormal. To me, I wouldn't think that AH would add anything. And then the vastus medialis was normal. And then my approach kind of skips the thigh muscles and just goes straight up to the hip girdle muscles, knowing that if they're abnormal, then I might avoid having to do some additional muscles in the thigh. But if they're normal, then I would go back down to the thigh. So that's just a little different. But in this patient, the gluteus maximus showed 3+ fibrillation potentials with some mildly long duration motor unit potentials. So it's just the medial gastrocnemius, the tensor fasciae was normal. So the medial gastroc and the GMAC showed a lot of fibs. And then I went to the S1 paraspinals and I didn't find any fibrillations. And I stuck it 3 times.
You mean 3 different sacral levels?
No, around the S1. So, but I, very close to S1, but angling the needle one rostral and caudal and central, and then kind of moved a little bit because I expected to find them there, and I didn't. So what do you make of all this?
Well, we know the lesion is proximal, but we don't know where it is proximally. It could be at the sacral plexus level. It could be at the intraspinal level. And we haven't been bailed out by the paraspinal muscle to help us localize. What I'm reminded of is some very old literature that tells us that the paraspinal muscle innervation can vary up to 4 to 6 segments different from the segment that you think is involved. And so I would have gone to lower sacral levels. And we did a study of single lumbosacral radiculopathies and looked at the presence or absence of paraspinal fibrillation in those lesions. And we found that there was the least likelihood of finding fibrillation in proven single radiculopathies based on MRI findings. The paraspinal abnormalities were least likely to be found in somebody with an S1 radiculopathy. And the more proximal the lesion, the more likely you would find fibrillation. So in other words, an L5 lesion, you could find fibs at the S1 level. At the L3-4 level, you'd start there, but if it wasn't fibrillating there, you'd be going down. And so I think it's on us as EMGers to make sure we've sampled enough segments to convince ourselves that we've fully assessed the potential level at which the fibrillation may be occurring. So I'm not surprised that there's no fibrillation at the S1 level.
So I think this is a fantastic point and really what I wanted to get at. And so you think this is a radiculopathy, this is a root problem, and it sounds like if I'm putting words in your mouth, less likely a plexopathy, but and
Well, wait a
or
second.
okay, I won't put words in your mouth.
Um, the um, the needle exam gets us this far, but the nerve conduction studies have to be aligned with, there has to be internal consistency among all the data when we make our interpretation. And so we still have a mismatch here.
Mhm.
We've got a high root level-ish kind of lesion on needle exam, and we've got a problem with sensory, S1 sensory
Mhm.
responses. So we have to somehow reconcile those two things.
So how would you reconcile? What could you do anything else? Because this was my predicament in this case. This is exactly what was going through my mind. What do I think here? What do I say in the report? Is there anything else I can do to clarify this?
In the EMG lab, um, I'm not sure. I think um, I'm not sure what we could do to further define this lesion, knowing the data we have. Um, and we're going to have to be careful about how we make our interpretation in the report.
How about outside of the EMG lab? Is there any way we can clarify it?
Well, this person is destined to have an MRI scan of the lumbosacral spine.
Yeah. And that's what they had. And I agree completely. There wasn't anything else I could think of, but at the L5S1 level to the left side, there's a large extruded fragment here. It might be hard to see, but you can see the narrowing.
Yes,
So that helps.
it does. Um, I think that it's hard to deny the likelihood that that could be contributing to the patient's EMG findings and symptoms.
Yeah. And I think, and of course, this is an obvious point, but in the context of the patient's history, a young, healthy man not having this continuous progressive problem which might make you think of a plexopathy if it was slowly progressive, has a long-standing history of intermittent back pain. It sounds radicular, sounds like an S1 radiculopathy. You have an imaging. So yeah, I mean, to me, this is pretty clear, but even in my report, what I said, because you can't be entirely sure, is I said, this is almost, this is most likely an S1, and while a sacral plexopathy can't be completely excluded, it's much less likely, or some wording like that.
So I'm interested in the radiologist's uh, assessment, and is this in the lateral recess? Is this actually invading the foramen? Because is it possible that the DRG is affected in this lesion?
Yeah. And that's kind of, you started alluding to that, and I'm going to just show real quickly, this whole issue of what you already alluded to. And this is your paper, which you well know and is cited so much. It's a great paper about the superficial fibular center response in L5 radiculopathies that can certainly be affected. You presented a number of cases, and there have been other studies showing a certain percentage of patients due to the location of the DRG. So I think not everyone knows this, but this, for those of you watching or listening, should know this, that the superficial fibular can be affected in a L5 radic. But what about the sural and an S1? And as you said, that doesn't happen very often. And there are other papers, I'm not going to go through all this, but there are other papers looking at both L5 and S1 showing it. I think you alluded to your series too, where it's a very small, this paper, only 2% of patients with S1 radiculopathies had sural involvement. And I think and you talk about this in your discussion, I think it has to do with the location of the DRG, and the S1 DRG, the S1 root, and tell me if this is incorrect, but the S1 root, when it's affected, is usually an L4, L5 disc. So it's more proximal to the
Yes.
to that.
Or an L5S1 disc, but that's not where the foraminal exit zone is, because that's already in the sacrum. So they're not kind of co-localized, the disc lesion and the
Right,
root.
right, right. And I think in that image that I showed you, I don't have the radiologist report, but I suspect that DRG was affected. Wherever that DRG was located was affected
Yeah.
here.
I think it's a good teaching point for all of us, and this is certainly an instructive case for me, that at the S1 level, if we're going to try to be internally consistent with the data we have and what we know now clinically and radiographically, that one would have to say that the S1 sensory fibers were also affected in this patient.
Yes. The sensory fibers from the DRG or distal or
Yes.
distal. Yeah. Yeah.
Yes.
Yeah. No, yeah. And I think going back to the point of the paraspinals, to be honest, these are the cases that I get frustrated, but kind of with myself, that, and it's happened with L5 too, where you know the patient has a prominent L5 radiculopathy, there are fibs in all the L5 muscles. I go to the L5 paraspinals and I just can't find them. And I do stick several different levels. And I think there are several reasons. You alluded to I think the primary reason that the L5 root, where we're putting the needle, may not be in the part of the paraspinals that are innervated by the L5 root. I think the other things is sometimes people may not tend to go deep enough, that the deeper layers of the muscle may show the fibs, and sometimes people are a little scared to go too deep in the paraspinals and get down to the lamina. I don't know if you've had that experience.
Yeah, so the so-called multifidus paraspinal muscles are, that it's said they have more localizing value. And I'm afraid I'm blocking on the name of the physical medicine rehabilitation physician at the University of Michigan who has looked at this with a number of studies.
Oh yeah, Dr. Haig, who did the
Andrew
paraspinal
Haig,
mapping, and
yes,
yes,
yes.
yes,
His point is that go deep, young man, go deep kind of thing,
yeah, and check multiple levels, which
Yes,
again, it's
yes,
uncomfortable. You don't want to do that to the patient, but I think when it's important, in this case, cases like this, that to check several levels, make sure re-angling, but don't be afraid to do that, I think is very important.
yeah.
So well, this is wonderful. I'm glad to pick your brain. I know this seemingly, I think what's interesting is it's a seemingly straightforward case that we see all the time, right? We see radiculopathy. That's the most common thing we see in our lab. But yet you get into it, as you said at the beginning, and sometimes the data just doesn't fit the textbook. There's some unusual findings that make it more challenging to know, to be as comfortable, and it's important for everyone to be aware of the variations that can occur in this from the anatomy.
Yes, and I think it also points out the fact that we need to be honest about the way we interpret our data, that there needs to be internal consistency in the data and how we report them. And we shouldn't be afraid to be equivocal or have a differential diagnosis from the EMG, as opposed to having to be absolutely dogmatic about the diagnosis.
Yes, and going back to the very basics of putting the findings in the context of the patient's clinical features. And I know if you, there's this movement towards AI and automatic interpretation of the data. And if you threw this data into a machine and said, where's the localization, it's going to come out as sacral plexopathy.
Yeah,
And so you have to take this into the context of the patient.
absolutely.
So, well, this has been the best Valentine's Day present. It's better than eating a box of chocolates. It's a box of knowledge with Dr. Levin. So I appreciate you taking the time, Carrie, taking your hour to discuss this. It's really wonderful to see you and always learn from you.
Well, it's a pleasure, and I think it's the other way around about the learning process. I've learned more from you than you've learned from me. But in any event, I very much appreciate the opportunity to talk about my favorite subject, EMG.
Well, great. Well, thanks. And next time we see each other, we'll go for a walk and we'll talk about how Wi-Fi works again, or AI,
Okay,
or
you'll
Chat
teach me.
GPT. We'll figure that one out. All right. Well, be well. Look forward to seeing you. Thank you.
Thank you.
Bye-bye. Well, I hope you enjoyed this episode. That was really a tremendous discussion. And as you heard or saw, there are lots of intricacies to evaluating a patient who we suspect has a lumbosacral radiculopathy. I always learn from these that there are different approaches. Dr. Levin performs certain studies that we don't usually perform. We perform some that he doesn't perform. But I think the most instructive points, as we said at the end, were that not everything fits the textbook, that sometimes we obtain abnormal sensory studies in L5 or rarely S1 radiculopathies. Sometimes the paraspinal muscles aren't always abnormal, and there are reasons for that, and it's important to consider that and think about the patient and the findings in the context of the patient as you come to your diagnosis. So I hope that this has been helpful. Enjoy learning, enjoy thinking about these cases, and look forward to next time. Bye-bye.